Let's start our new video regarding the English vlog regarding the new surgery. I am Dr. Muhammad Kazafi, and you are watching Dr. Muhammad Kazafi Views. And Assalamu alaikum. This is Islamic greeting for everyone, and good morning for the people they are listening me in morning, and the good evening the listening people are listening me in the evening. The today's topic is a very common topic and very important one, and I think anybody who worked in neurosurgery, I think definitely he had encountered this topic multiple times maybe. I don't know, countless time I have been encountered with the chronic subdural hematoma. When I chose this topic, I was thinking that it could be worth to I can discuss this topic. Then I realized that if the more common topic, then we have to discuss more, because then we could understand more. And if any ambiguity, it should be clear. Any doubts, if somebody has, it should be clear. So that's all. Without wasting your more time, I just want to start this topic. It is called a chronic subdural hematoma, and like always, I am taking one analogy here, and this analogy is the one case of mine is about a 72-year-old female with end-stage Alzheimer's disease, diabetes mellitus, and she is nursing homebound, is brought to the emergency room, and for a 3-day episode of the increasing confusion, agitation, irritability, inappropriate behavior, and the patient is confused at baseline. However, she was noted to be combative and refusing her care, as well as she was very much irritable, agitated, voicing aloud, and wanting to leave the place, or the hospital, or any place where she is at. So, which is very much unusual behavior for her, because she was not known for that kind of behavior. Definitely, and she is a poor historian, but she does not report having had a frequent fall in the near past. Physical examination reveals a left-sided pronator drift and confusion, and the remainder of the examination was within normal limits. We sent all the routine labs for her, as we are sending for every patient when the patients are presenting to us in the ER to check diabetes or any other problem which should not be hindered from us, and we should know about that problem. And simultaneously, we did the CT scan, because definitely she presented with the abnormal behavior, and we found there in the axial slices, we found there is a bilateral hypodense collection subdurally, equal in size and the same in shape, and the maximum thickness was 3 centimeters on each side, means 3 centimeters on the left side and 3 centimeters on the right side, with the with the ventricles were not dilated at all. I can say, brain atrophy was there, which is very much understandable because of the age. Because of this outside hypodense fluid, definitely suggestive, and it seems to be this chronic subdural collection, and definitely because the behavior is newly appeared, so definitely it's some acute subdural has been converted into the chronic subdural. So these chronic subdural bilateral collections presented with us. Now I want to present this case, and simultaneously I wanted to present in front of you this topic in detail, because analogy I took that because we can concentrate over that. Definitely this is a true patient, true history, everything, what we did, what we will do, no, what we did and what we have to do, definitely we will discuss with you. First of all, I want to discuss here the first, how we can interpret the CT scan. I try to interpret, but I will try again. A CT scan of the brain reveals bilateral subdural hematoma, which are mainly chronic with a very small subacute component on the right side. The right subdural hematoma is 2.8 centimeter in thickness, and the left subdural hematoma is 2.7 centimeter in thickness, and they both are mainly along the convexities in the frontal, and both mainly along the convexities in the frontal and somewhat parietal area. There is some diffuse brain atrophy in both frontal lobes, constitute with advanced Alzheimer's disease, and this also appeared to be the no midline shift, no obvious mass effect and the edema, but the basal systems we can see and we can appreciate. There might be some effacement in the sulci along the cortical surface in the frontal lobe area. So what could be the other information we want to obtain for the management? We obtain current medication history, especially whether or not she is on anticoagulants, determine if there is a living will or a durable power of attorney. If so, determine the patient's wishes in the situation where the life-saving measures are needed and nobody with her. And we wanted to know, is there any trauma of she fall or any event which you consider that maybe this is a trauma or breakage of the bridging veins or anything. The further investigation, I just want to tell, because I already mentioned that the laboratory test complete blood count, electrolytes, coagulation profile, types and screening, and other imaging modalities such as the MRI, unlikely to change your management in this case. But if we do surgical intervention, definitely is contemplated, then medical clearance may be needed, such as the EKG, chest X-ray, cardiac echography. We definitely want the opinion from the cardiologist and the internal medicine, because we want to intervene. So here, what we could tell to the family or next of kin or caregiver, definitely the patient has fluid collection on the surface of her brain, which are likely due to the old hemorrhage, and it is not clear whether or not these fluid collections are causing a lot of pressure on her brain, and she also has a brain atrophy due to the Alzheimer's disease, and she may possibly benefit from the evacuation of the fluid collection. However, the caregiver need to be aware of that fact, that evacuation may also not helpful, as she may progressive dementia due to the Alzheimer's, and she may also have complication from the surgery. We have to inform the caregiver of all the potential surgical complications, which include but are not limited to the pain, bleeding, infection, failure to treat, presenting condition, need for the further surgery or procedures in future. Reaccumulation of the fluid collection causing damage to the adjacent blood vessels, nerves, and the tissue. Additional loss of the brain function such as memory, stroke, changes in vision, deafness, instability to stand or coordinate, inability to smell, coordination loss again, seizures, cerebrospinal fluid leak, weakness, impaired muscles function, numbness, paralysis, or death. So, how would we approach this case surgically? Actually, how I can and I want to describe you the steps of the surgery, including the positioning, incision, bone opening, and evacuation and closure. As you know that we have one operative option which consists of bilateral burr hole evacuation of subdural hematoma, with the two burr holes placed on each side is also an option. Preoperative preparation include preoperative antibiotics such as cefazolin 1 gram intravenously every 8 hourly, preoperative seizures prophylaxis such as phenytoin loading dose of 1 gram IV over 1 hour, and followed by the maintenance dose of 100 milligram 8 hourly, and positioning. Definitely once the patient we will and after getting the consent, definitely under the OR and after all aseptic measures, and supine position with head and bed slightly elevated, anesthesia, preferably conscious sedation or the general endotracheal if the patient will tolerate it. Definitely, when you are doing like that, so you are avoiding the cardiac and the pulmonary risk factors. Surgical steps such as clip the hair and mark incision along the convexity in the line with each other, such that if the need for the bone flap arise, it will suffice to connect both entries or incisions. As you know, the incision should be 5 to 6 centimeter away from the midline, one along the parietal bone and one just behind the hairline anteriorly, and both 3 centimeter in length, and start by opening the right side, as this is the symptomatic side, and start by opening the right side. On this is the as I mentioned already, the symptomatic side, and open skin galea and then periosteum with the number 10 blade, expose the skull and make a burr hole, then 2.5 centimeter in diameter with a pneumatic drill, wax the bone edges and cauterize the dura, open the dura in the cruciate incision or cruciate fashion, then drain the blood, irrigate both burr holes profusely with normal saline until the drainage becomes clear or like the crystal clear. One may place a catheter in the burr hole subdurally and further irrigate to dislodge any pocket of blood that are harder to access. In the same setting, closure is completed by placing a piece of a gel foam, like if gel foam available, otherwise any hemostat, such as people sometimes using the surgical. On top of the burr it should be applied. Then we close the skin engalia with 30 vicryls, and one may leave a small drain in the subgaleal space. The patient is kept with the head little, means we can say upward, or so we can avoid any further bleeding, and post-operatively we can convert into, when we shift patient in ICU, then we can place the bed a little, means we can say on a flat position, a little from head and little lower sometime, so it can give the chance to collection should come out from the catheters. Both options are very good, and both options are working good for me. Pre-operatively, as we plan the surgery, she develops hyponatremia with sodium was about less than 120, and she became lethargic. And what were the causes for the hyponatremia, and what were the most likely treatment or correction? And what could be the causes for hyponatremia? So I just want to discuss with you in little detail. So I wanted to present in front of you these all causes of hyponatremia. As you know, hypovolemic hyponatremia, sodium and free water loss with inappropriate hypotonic fluid replacement. Cerebral salt wasting syndrome, traumatic brain injury, aneurysmal subarachnoid hemorrhage, subdural hematoma, and postcraniectomy the most likely cause in this case. I want to mention the cerebral salt wasting syndrome, traumatic brain injury, aneurysmal subarachnoid hemorrhage, subdural hematoma, and postcraniectomy the most likely cause in this case. Gastrointestinal loss due to the vomiting or the diarrhea, excessive sweating, third space of fluid, peritonitis, pancreatitis, burns, acute or chronic renal insufficiency, prolonged exercise in a hot environment, euvolumic hyponatremia, normal sodium store and a total body excess free water, psychogenic polydipsia. I'm just telling you that the euvolumic hyponatremia is little different. Before I told you the hypovolumic hyponatremia, such as in my case. But the euvolumic hyponatremia in the normal sodium store and total body excess free water, which is the pyogenic polydipsia, and hypotonic IV or irrigation fluid post-operatively. If somebody used the hypotonic fluid, then it can cause hypervolumic hyponatremia, inappropriate increase in sodium store, hepatic cirrhosis, congestive heart failure, nephrotic syndrome, hypothyroidism, cortisol deficiency, syndrome of inappropriate antidiuretic hormone SIADH, medications such as acetazolamide, thiazide diuretic, angiotensin converting enzyme inhibitor, carbamazepine, gabapentin, haloperidol, heparin, loop diuretics, nimodipine, opiates, proton pump inhibitors, and selective serotonin reuptake inhibitors. So this was the list which I mentioned in front of you for the hyponatremia. How would we manage this problem? Actually, to ensure the patient in a stabilized, first secure airway, what we did, then we did breathing, circulation, and trauma place checking if needed, oxygen transfer during the patient transfer to the intensive care unit. We maintain the IV line, large bore hole IV line. We place the Foley's catheter so we can check the output also. And we obtain following laboratory studies such as for the hyponatremia. So the serum and urine sodium and osmolality and the serum specific gravity and the serum electrolytes were very, very important in that regard. Thyroid function studies and the adrenal function studies were also very important, and in this case the most likely cause was hypovolemic hyponatremia, and which is possibly due to the subdural hematoma. And as the symptoms were mild to moderate, and that's why it was treated with the isotonic saline. So the monitoring of the serum sodium level needed to be done frequently to ensure that the serum sodium does not increase more than 0.5 milliequivalent per liter per hour or 12 milliequivalent per liter per day. Hypertonic salines 3% may be used as an alternative of the normal saline alone is not the adequate enough to correct the problem. When using this solution, care should be taken to administer it slowly, and frequent check on the serum sodium were required every 2 to 4 hours. Evacuation of subdural hematoma may resolve, and the hyponatremia it did in this case. So what is our course of action now? Urgent ICU admission we did. Laboratory studies such as the complete blood count, electrolytes, coagulation profile, type, blood typing, screening, blood urine, sputum culture, and culture discharge from the wound, which was not in that case, but we could consider if needed. As you know, urgent ICU admission we did already. So obtaining the imaging study, we already did CT, MRI with or without contrast, and we did start of the broad spectrum antibiotics because we already started cefepime to her, and we can, in other case, in some where the infection we are considering high, then definitely we could increase the quality of the antibiotic or strength of the antibiotic, such as we can go to the vancomycin and 1 gram IV every 12 hourly, cefepime 2 gram IV every 12 hourly, 12 hourly, metronidazole 500 milligram IV every 8 hourly, gentamicin 6 milligram every 8 hourly may be used instead of cefepime if the patient is allergic to penicillin. Antibiotic changes are performed as the culture and the sensitivity result are obtained. This should be the policy. Follow-up CT scan and subsequent an MRI scan could be done and should be done. And so how we can interpret if there are some differential diagnosis like that. For example, CT scan with the contrast shows some reaccumulation of the fluid bilaterally, and the fluid collection on the right side is partly hyperdense or enhancing, which is suggestive for the acute blood or possible empyema with peripheral enhancement. Or if we do the MRI, the subdural fluid is consistent with the blood of different age, and it is seen bilaterally, and on the right side there is some enhancement surrounding the subdural fluid, which is possible suggestive of the infection. So we should know that the right subdural fluid appeared to be iso to hyperintense on T1 weighted and hyperintense on T2 weighted on the fluid attenuation inversion recovery MRI, which is also called the flare MRI. I just want to mention you the flare MRI. If we talk in detail, what we say, the fluid attenuated inversion recovery MRI, which is called the flare MRI. If it is blood and it is likely subacute to chronic, it means chronic means 3 weeks older. So the differential diagnosis here, reaccumulation of the subdural hematoma or subdural empyema or subdural hygroma. So what we or how we can plan the management here? Actually, general surgical evacuation via burr hole re-exploration on the right side we could do again, and the exposure should be prepared in the event that a craniotomy is needed. Sometimes craniotomy needed. That's why we placing the incisions parallel on each side, while we can use that incision to make a flap, and then we can perform the craniotomy. So the subdural fluid needed to be sent for culture as soon as possible, after which the antibiotics are initiated. Incision and the sharp debridement of the posterior scalp wound is needed with irrigation and antibiotic and saline if the infection suspicion. The drain can be left in the subgaleal space. Wound closure can be done in a single layer with 2,0-proline that promotes better healing, especially in the infected or granulation tissue. So this is I talk about little my chronic subdural chronic patient, but I want to discuss, because maybe this video become longer, but I want to talk you about the subdural hematoma a little more. Chronic subdural hematoma is one of the most common neurosurgical condition, and there is a lack of uniformity in the treatment of the chronic subdural hematoma among the surgeon in terms of various treatment strategies. Because when I was under training, I was trained by the roughly 8 to 9 neurosurgeons, and almost everybody has their own technique to treat the chronic subdural hematoma. I learned from all of them, and definitely when I'm doing, there is some impression from every of my teacher is coming in my practice. So the clinical presentation may vary from no symptom to unconsciousness. Chronic subdural hematoma is usually diagnosed by contrast-enhanced computerized tomography scan. Magnetic resonance imaging scan is more sensitive in the diagnosis of bilateral isodense chronic subdural hematoma. Multiple loculation, intrahematomal membrane, fresh bleeding, hemolysis, and the size of capsule all has to be looked after by the neurosurgeon. Contrast-enhanced CT or MRI could detect associated primary or metastatic dural disease, although definitive history of the trauma could be obtained in a majority of cases. Some cases may be secondary to the coagulation defect, intracranial hypotension, use of anticoagulants and antiplatelet drugs, etc., etc. Recurrent bleeding, increased exudate from outer membrane, and cerebrospinal entrapment have been implicated in the enlargement of chronic subdural hematoma. Burr-hole evacuation is the treatment of choice for an uncomplicated chronic subdural hematoma. Most of the recent trials favor the use of drain to reduce recurrence rate. Craniotomy and the twistal craniostomy also play a role in the management. Dural biopsy should be taken, especially in the recurrence and thick outer membrane. Neurosurgical management is reserved for asymptomatic or in recurrence and thick outer membrane. Neurological management is reserved for the asymptomatic or high operative risk patient. Simultaneously, the steroid and the angiotensin converting enzyme inhibitor may also play a role in the management. Single management strategy is not appropriate for all the cases of chronic subdural hematoma. Better understanding of the nature of the pathology, rational selection of an ideal treatment strategy of an individual patient, and the identification of the merit and the limitations of the different surgical technique could help in improving the prognosis. As you know, the chronic subdural hematoma is one of the most common neurosurgical conditions, and the preferred surgical method continue to attract debate. There is a lack of uniformity about the treatment strategy, such as the role of burr-hole, twist drill, craniotomy, etc., etc. Chronic subdural hematoma, amongst the various surgeons, there is also disagreement about the use of drain, irrigation, or steroids. But the incidence of this hematoma is so high, that's why a lot of people suffered this problem, and a lot of neurosurgeons encountered this kind of cases multiple times in their life. The presentation of the chronic subdural hematoma could vary from no symptom to headache, seizures, decreased memory, and confusion. Patient could have difficulty in speech, swallowing, and walking. There may be weakness or numbness of arms, legs, and face. The chronic subdural hematoma are usually characterized by history of head trauma, which is usually a trival trauma, and some cases could be secondary to defective coagulation. After lumbar puncture, chronic subdural hematoma should be suspected in a patient who present with unusual presentation or unusual persistent headache after spinal anesthesia or LP, like LP means lumbar puncture. Chronic subdural hematoma should be taken into account as an important differential diagnosis in reversible or irreversible dementia. The differentiation between chronic subdural hematoma and dementia could be difficult when it is associated with hallucination. Chronic subdural hematoma generally occur in elderly, although it may present in a young patient, and it may rarely be seen in infant. The presence of the bilateral chronic subdural hematoma in an infant arises the suspicion of non-accidental trauma and present a difficult diagnostic challenges because of the legal and the social implications. The glutaric aciduria type 1 should be considered in the differential diagnosis of bilateral chronic subdural hematoma in infant, and some chronic subdural hematoma of infancy may have congenital etiologies. The chronic subdural hematoma are usually on the most curved frontal and occipital convexity. Bilateral chronic subdural hematoma is common in patients with symmetrical frontal and occipital cranial vault, a symmetrical cranium, chronic subdural hematoma are usually on the side of the most curved frontal and occipital convexity, which is more frequent on the left side. Although chronic subdural hematoma are usually on the convexities interhemispheric, chronic subdural hematomas can also be seen. So, the isolated third nerve palsy may occur in the chronic subdural hematoma, and movement disorder such as the choreo, or we can say chorioethatoid and Parkinsonism could be associated with the chronic subdural hematoma. Pressure effect, neurotransmitter abnormalities, and the ischemia have been postulated are the reason for this type of presentation. Elderly people suffering from the subacute progressive Parkinsonism should undergo computerized tomographic studies to differentiate it from the primary Parkinsonism. This Parkinsonism is usually completely cured after successful evacuation of the hematoma. Catatonia could be observed in chronic subdural hematoma. Resolution of the bell for spasm has been observed after the evacuation of chronic subdural hematoma. Chronic subdural hematoma can cause void dysfunction with small bladder capacity and the high amplitude on overactive detrusor contraction with an intact sphincteric response. So the spinal chronic subdural hematoma may coexist with the intracranial subdural hematoma. Magnetic resonance imaging of the spine is indicated in the suspicion patient with the cranial chronic subdural hematoma sometime. In a radiological point of view, chronic subdural hematoma usually diagnosed by the CT scan, and hematoma are usually hypodense but isodense or the mixed density lesions are also observed according to the age of the blood or the clot or the collection. Although these are usually concavo-convex, rarely may have mimic acute epidural hematoma. The chronic subdural hematoma could be globular, rarely due to the severe craniocerebral disproportion secondary to associated with cerebral mental. Huge hemispheric chronic subdural trauma occupying whole cerebral hemisphere and compressing the falc with almost complete obliteration of the ipsilateral lateral ventricle has been reported and multiple times has been seen. The calcified chronic subdural hematoma, though rare, could mimic calvarial mass, and the contrast images are essential to find out any associated primary or metastatic dural disease. The formula half ABC has been validated to be relatively reliable method in the estimation of the acute subdural hematoma, intracerebral and epidural hematoma. This method could underestimate some chronic subdural hematoma. The formula 2 out of 3, which is called the SH, can be used to estimate subdural hematoma. Is this the largest axial hematoma slice and the depth and the multiplied by the 2 by 30, 2 by 3. So this is a simple, precise and convenient method to estimation of the volume in all the types of the hematoma. Bilateral isodense chronic subdural hematoma may cause considerable difficulty in diagnosing by CT scan, MRI, and could CT scan or MRI. So, but MRI could help in making the diagnosis of the such lesions, and MRI is more sensitive than the CT scan in determining the size and internal structure of chronic subdural hematoma, such as the multiple loculation and intrahematoma membrane. Fresh bleeding, hemolysis, and the hemoglobin changes can also be observed by MRI. The diffusion tensor imaging can examine anisotropic changes of pyramidal tract displaced by the chronic subdural hematoma. These anisotropic changes are considered to be caused by reversible distortion of the neuron and vasogenic edema by the hematoma. So these changes in the affected pyramidal tract correlate to the motor weakness in chronic subdural hematoma. And the diffusion weighted image and the enhanced MRI imaging are usually useful for the diagnosing infected chronic subdural collections, and contrast enhanced MRI could detect neomembranes, which are sometimes thick and extensive membranes, or sometimes solid, or like a solid clot. In the differential diagnosis, if we considering the subdural hematoma could be seen in associated with the primary dural disease or the metastasis, such lesion could be missed and could be the cause of recurrence in chronic subdural hematoma. A contrast-enhanced brain CT scan is recommended to diagnose dural metastasis. Rosai-Dorman disease may be mistaken by the chronic subdural hematoma on imaging. The disease is an uncommon, benign, systemic and a proliferative disease characterized by the massive lymphadenopathy, particularly in the head and the neck region, and often associated with the extranodal involvement. Chronic subdural hematoma can also develop in multifocal fibrosclerosis, which is a rare disorder of unknown etiology and characterized by the chronic inflammation with dense fibrosis and the lymphoplasmacytic infiltration into the connective tissue of various organs. The mechanism of the formation of chronic subdural hematoma is presumed to involve a reactive granular membrane together with the subdural collection. On the other hand, the extramedullary erythropoiesis within chronic subdural hematoma can be confused with the metastatic malignant tumor such as the lymphoma, carcinoma, or the malignant melanoma. Etiology is very common but very important to understand. Although majority of the chronic subdural hematoma are due to the trauma, intracranial hypotension, and defective coagulation could also be the responsible. Post-traumatic definitive history of the trauma could be obtained in a majority of cases, and the majority of these cases have mild head injury, although moderate to severe injury could also be causative factor in some cases, and the injury could be trivial and may go unnoticed sometime, or some cases could occur after neurosurgical operations. So it also a type of a trauma, but it's a iatrogenic trauma. The thin wall of the thin walls of the bridging veins, circumferential arrangement of the collagen fiber, and the lack of the outer reinforcement of the arachnoid tuberculi contribute to the more fragile nature of the bridging veins in the subdural portion as compared to the subarachnoid portion. Repeated injury on the head during play may be the cause of the chronic subdural hematoma in children. Chronic subdural hematoma can evolve from acute subdural hematoma or subdural effusion. Matrix metalloproteinase is thought to play a role in the development of chronic subdural hematoma. About half of the asymptomatic traumatic subdural empyema ultimately involve into the chronic subdural hematoma. So, the rupture of the bridging vein, bleeding from the hygroma hygroma wall due to the neocapillaries and the vascular hyperpermeability, increased fibrinolysis, increased protein content in the hygroma are some of the explanation of the pathogenesis of the traumatic subarachnoid effusion evolving into the subdural hematoma. So this subdural effusion sometimes cause of the development of the subdural hematoma, and inflammatory cytokines are elevated in the subdural effusion and simultaneously in chronic subdural hematoma as compared with the peripheral venous blood. So it is hypothesized that the subdural effusion and chronic subdural hematoma are the different stages of the subdural collection with different appearances of the same inflammatory reaction. Intracranial hypotension, the cerebrospinal fluid leakage could cause intracranial hypotension, which could lead to the chronic subdural hematoma. And the spontaneous intracranial hypotension could be the cause of the chronic subdural hematoma, especially in young to middle-aged patients without proceeding hematoma or hematological disorder. So the MRI scan of the spine and the radionuclide cysternography are useful in the evaluation of the intracranial hypotension, and the presence of an underlying spontaneous spinal CSF leak could be considered in chronic subdural hematoma even among the elderly taking anticoagulants. So the CSF rhinorrhea could be the cause of the intracranial hypertension and leading to the chronic subdural hematoma. Intracranial hypertension following the lumbar puncture, spinal anesthesia, and the spinal surgery, the possibility of the intracranial subdural hematoma as a complication of the puncture of the dura mater could be suspected, especially in post-lumbar puncture headache of more than 1 week. So the neuroimaging is necessary after 1 week of the lumbar puncture if the patient continue to have headaches. Chronic subdural hematoma could be considered when postpartum patients who have received epidural anesthesia and present with a mild to severe persistent and non-postural headache. So the chronic subdural hematoma could occur after the microdiscectomy complicated by the delayed CSF leak. Intracranial hypertension due to the sudden decompression of the intracranial lesion. Chronic subdural hematoma can develop due to the intracranial hypotension secondary to the sudden decompression of the intracranial pathologies such as suprasellar araconite cyst fenestration and the endoscopic third ventriculostomy. So the coagulopathy is also creating a big role to develop the chronic subdural hematoma, and the anticoagulants or the antiplatelets are the major drug can cause this kind of problem. Chronic subdural hematoma could develop in the presence of the potential hemorrhagic dysesthesia due to the deficiency of the clotting factor, such as the clotting factor, we can say here, clotting factor 8 and 13, and deficiency may play a pathophysiological role in spontaneous chronic subdural hematoma. So the factor 13 activity could be investigated because it may predict rebleeding event after the treatment. Factor 13 substitution may prevent recurrence in individual with considerable low factor 13 activity. So the chronic subdural hematoma could develop in patients receiving antiplatelets and anticoagulation therapies. The pathology, that this is definitely a very, very important part of this thing. I want to mention here definitely because even though I am noticing this video is getting longer, but definitely the few important aspects we cannot leave unaddressed and we cannot complete until unless we can address all the aspects of the chronic subdural hematoma. Chronic subdural hematoma consists of an outer membrane hematoma activity and an inner membrane. Hematoma fluid is usually liquid that does not clot. Usually hematoma are liquefied, but mixed lesion with solid component are also can be seen on the CT scan and appreciated. The higher concentration of the fibrinogen and D dimer are seen in the layered and the mixed layer of the chronic subdural hematoma. The fibrinolytic factors appear to be associated with evaluation in chronic subdural hematoma with heterogeneous densities. Usually there is no infection in these hematoma, but chronic subdural hematoma is a potential site for the bacterial infection. The possibility of the infected chronic subdural hematoma should be considered when a patient has a feature of infection. And the developing hematoma capsule show gradual changes in the cellular and the vascular organization with progression in the hematoma age, and the limited changes include the angiogenic and aseptic inflammatory reaction. It is followed by the fibroblast proliferation and development of the collagen fibers. Young hematoma around 15 to 21 days after the trauma show numerous capillaries and suggesting formation of the new blood vessels. So the older hematomas, such as the 40 days after the trauma, usually show numerous capillaries and thin-walled sinusoid accompanied by the patent large diameter blood vessels, and these blood vessels are frequently occluded by a clot in the fibrotic outer membrane of 60 or more days or older hematoma. The outer capsule may calcify and ossify in some cases, and definitely when it gets ossified, it's little difficult to treat and little difficult to handle. Chronic subdural hematomas cause decrease in the blood flow in the underlying brain, and the drainage of the hematoma result in the improvement of the cerebral blood flow and clinical recovery. The chronic subdural hematoma could be associated with reversible distortion of underlying nerve fiber and vasogenic edema. Chronic subdural hematoma could be associated with the spinal chronic subdural hematoma in cranial hypotension. Expansion of hematoma, such as the pathology of the enlargement of the chronic subdural hematoma, is very complex, and it is likely that the multiple factors are responsible for the maintenance and the enlargement of the chronic subdural hematoma. The relative importance of such varies from case to case. There is a great variety of chronic subdural fluid type, ranging from bright red liquid through the thick engine oil to light serous fluid could be the presentation. Similarly, some chronic subdural hematoma contain a very thick outer membrane, whereas in the other, the membrane is hardly visible with the naked eye. And the complete nature of the chronic subdural hematoma pathology can be explained by the recurrence of the hematoma even after the complete removal of hematoma and the outer membrane, whereas an partial removal of the clot and can lead to complete resolution of the hematoma and the membrane. So the rebleeding exudate from the outer membrane, osmotic theory, and the rapid enlargement due to the CSF entrapment are considered as a possible cause of the expansion of the hematoma. Rebleeding also the cause. For example, the chronic subdural hematoma enlargement from the recurrent bleeding in the subdural space caused by the local angiogenesis, inflammation, defective coagulation, ongoing fibrinolysis, rebleeding from the thin-walled sinusoidal blood vessel in the outer membrane has been proposed. So, the new hemorrhage encounter for about 6 to 7% of the hematoma content. Coagulopathy, anticoagulation, antiplatelet drug, excessive coagulation in the hematoma is considered for the progressive enlargement of the chronic subdural hematoma. High fibrinogen degradation products has been detected due to the hyperfibrinolysis in chronic subdural hematoma. There is a reduction in the clotting factor 2, 5, 7, 8, 9, 10, 11, and 12. These factors can be reduced, and this can cause the expansion of hematoma. And the high tissue plasminogen activator when concentrate in the subdural fluid and the outer membrane could cause rebleeding, and such patients have a relatively higher probability of the recurrence. And the plasminogen activator inhibitor type 1 deficiency could be the responsible for the recurrent chronic subdural hematoma. Local inflammation and the angiogenesis. Local inflammatory process in chronic subdural hematoma resulting in the formation of the granulation tissue, often referred to the external or the outer membrane. Significant higher level of the pro-inflammatory interleukins such as and the anti-inflammatory mediator interleukin 10 and interleukin 13 have been reported in chronic subdural hematoma fluid as compared with the systemic level. So the pro-inflammatory tumor necrotic factor and the significantly lower in the hematoma fluid compared with the systemic level. So the ratio between the pro-inflammatory and inflammatory cytokines are significantly higher in chronic subdural hematoma are as compared to the systemic level. So these findings suggest that the local hyperinflammatory and low anti-inflammatory response exist simultaneously, and they also suggest poorly coordinate innate immunity response at the site of chronic subdural hematoma, and this response may lead to propagation of the local inflammatory process, which could contribute to the formation and progression of chronic subdural hematoma. Local inflammation seems to be responsible for continuous bleeding by capillary exudate in the earlier phase, but the various inflammatory markers such as interleukin 6 and interleukin 10 and the chemokines have been found to be elevated in chronic subdural hematoma and are implicated in the genesis of the chronic subdural hematoma. Angiogenesis appears to render maturation of outer membrane by spouting vascular networks in the late phase of the chronic subdural formation. Enhanced expression of the angiogenic growth factors such as vascular endothelial growth factor and the basic fibroblast growth factor in the outer membrane is associated with the expansion of the chronic subdural hematoma and the recurrence. So the hypoxia inducible factor 1 release and a VEGF could be responsible for excessive development of fragile microvessels and hyperpermeability, resulting in enlargement of the chronic subdural hematoma. So the cyclooxygenase 2 pathway has been shown to influence angiogenic factor, which is called the COX-2, may play a crucial role during the development of the chronic subdural hematoma. As I mentioned, chemokines and the cytokines also play very huge role here. Definitely, the osmotic theory of the maintenance and growth of chronic subdural introduced by the Gardners and later modified by the Zollinger and Gross has been largely abandoned after Weir's publication. So the CSF entrapment is a major cause for the expansion of the hematoma, and the chronic subdural hematoma enlargement could be due to the flow of CSF through some area of the inner membrane and the enlargement of CSF in the cavity. You know that the treatment surgery is the treatment choice in the most of the chronic subdural hematoma. Some of these patients could be managed conservatively, especially a small hematoma after antiplatelet drug use, and there are observation of the normal mean subdural pressure in chronic subdural hematoma. Some of the small chronic subdural hematoma after antiplatelet drug use can be managed conservatively by stopping the antiplatelet drug and follow up with the repeat CT scan, and when surgery is necessary, its delay, and if patient condition permits, allow metabolizing the drug and the platelet renewal. So then this delay could minimize the risk of the hemorrhage, and if urgent burr hole are indicated, measure to improve platelet function should be undertaken. And there is a general agreement that the significant coagulopathy should be reversed and expeditiously in chronic subdural hematoma before the surgery is planned. So the recombinant activated factor 7 has been recently gained popularity for the rapid reversal of the coagulopathy during chronic subdural hematoma surgeries. Some of the patients with the normal international normalized ratio can have excessive intraoperative coagulopathic bleeding, and also we saw normal INR should not be the deterrent for patient to receive what we say the recombinant activated factor 7. And in the setting of the strong neurosurgical suspicion of the underlying clinical coagulopathy, there is an increased risk of the intraoperative bleeding in patients who are anticoagulant. There is also a risk for the complication of the anticoagulant are stopped in some patients. The optimal time to restart full dose anticoagulation when indicated after recently drained chronic subdural hematoma. Spontaneous resolution also has been seen in some cases, such as the chronic subdural hematoma with idiopathic thrombocytopenic purpura may resolve spontaneously, and with medical treatment, surgery might be deferred except in the emergency condition or in patient with the neurological deficit. So the close neurological and radiological observation along with the medical entrapment could be appropriate in patient with the normal neurological finding, and the neurotraumatic subdural hematoma or hygroma in infant can often experience significant resolution with several months without surgical treatment. Spontaneous resolution of the post-traumatic chronic subdural hematoma in patient without any associated coagulopathy though rare, can occur. Careful conservative treatment can be considered if the patient is neurological and physical condition allows. Administration of the platelet activating factor receptor antagonist atizolam can promote chronic subdural hematoma resolution, especially in the stage of the hygroma. Surgery is recommended if the patient presents with the motor weakness. A Campo medicine, which is a Japanese medication and has been found to be useful option in the conservative treatment of chronic subdural hematoma with no or minimum symptom in chronic subdural hematoma. Coagulation factor deficiency should be investigated and corrected to prevent recurrence, and the development of the anti-COX treatment option could reduce morbidity and the recurrence rate in chronic subdural hematoma. As I mentioned before, seizure prophylaxis is very important, and we should use and we could use. And the role of the steroid, here we can say, although the surgery is required in chronic subdural hematoma with moderate or severe neurological deficit, corticosteroid could be used in the mild neurological deficit, and the current evidence neither support or nor referred the use of the corticosteroid in chronic subdural hematoma, although there is a lack of well-designed trial that support or referred the use of the corticosteroid in chronic subdural hematoma. So in that regard, 5 observational studies suggested that the corticosteroid might be beneficial in the treatment of chronic subdural hematoma, and the extended pre-operative corticosteroid use along with the burr-hole craniotomy is associated with the lower recurrence rate, and the post-operative use of the corticosteroid has been associated with the better survival, and the use of the corticosteroid does not seem to be related to the higher incidence of the complication and the treatment-related death. So the dexamethasone has been found to be the safe option, and it has cured and improved 2/3 of the patient in retrospective studies. The true effectiveness of the treatment as compared to the surgical treatment should be tested in the prospective randomized trial. A steroid treatment in patients with the comorbidity is more option, and the oral corticosteroid therapy is very effective in chronic subdural hematoma due to the MFS. The role of appropriate hydration in subdural subarachnoid hemorrhage is well recognized. Intravenous fluid administration of at least 200 ml for 3 days post-operatively has been found to be associated with the better clinical outcome and reduced recurrence in chronic subdural hematoma. The appropriate fluid delivery may facilitate brain re-expansion and thus avoiding hematoma recurrence and accelerating patient's recovery. Surgery is the best option in the moderate to large hematoma with the neurodeficit, and one surgical technique may not be appropriate for all kinds of the chronic subdural hematoma. The selection of the ideal treatment strategy for an individual patient should be targeted. Removal of the chronic subdural hematoma is enough in most of the patients with associated chronic arachnoid cyst. Anesthesia is also may differ as per need. Burr-hole surgery can be done under local anesthesia in most of the patients, and the surgery for the chronic subdural hematoma under monitorized anesthesia using conscious sedation has been found to be safe and effective in some cases. But the conscious sedation using monitored anesthesia care may facilitate patient comfort and surgical competence in chronic subdural hematoma. Head positioning, incidence of the atelectasis, pneumonia, decubitus ulcer, deep vein thrombosis could be more if patients are kept in supine position post-operatively, especially in the elderly case. The 30-degree head-up position soon after operation in chronic subdural hematoma does not significantly affect the outcome and the recurrence, so the early mobilization after surgery could prevent post-operative pneumonia and urinary tract infection without increasing the risk of the recurrence in elderly patients of 65 years or more. Some authors, on the other hand, do not recommend upright position soon after surgery because of the incidence of the post-operative atelectasis, pneumonia, decubitus ulcer, and deep vein thrombosis is the same in 30 to 40 degree sitting position and supine position, but the recurrence rate are significantly more in the upright position. The subdural evacuation port system This is the subdural evacuation port system is a technique for the treatment of the hygroma, chronic subdural hematoma, subacute subdural hematoma, and SEPS can be done at the bedside under the local anesthesia. Use a small drill hole, and SEPS allow for the SPS such as the subdural evacuating port system. This SEPS or the subdural evacuation port system allow for the gradual re-expansion and recovering the brain. The port does not enter the subdural space and avoid the risk of the brain penetration, and there is no need for irrigation in this system. And this subdural evacuating port system provide a closed system for hematoma evacuation by gradual decompression using a uniform negative extradural pressure. And this subdural evacuating port system is a safe and effective alternative treatment option in elderly or the sick patient who might not tolerate the physiological stress of the craniotomy, or we can say the burr hole under general anesthesia. It is more effective in the hypodense subdural collection as compared to the mixed density collection, and significant bleeding after the subdural evacuation port system insertion, though uncommon, and it is very safe. The efficacy and the safety of the subdural evacuation port system is similar to that of the other twist drill or subdural method. The appearance of the winged cannula in the diploic space help the radiologist to identify it. Another minimal invasive technique of placement of the hollow screw under local anesthesia could be an effective treatment in most cases of chronic subdural hematoma. About 20% may need burr hole surgery after treatment with the hollow screw. Drainage is, everybody knows, considerable body evidence supporting the use of the external drainage after evacuation of the primary chronic subdural hematoma exists in most of the reports, and people are doing most conveniently this one, and they are very happy to do this one. So there are the different type of the drainage system. For example, the subdural, subperiosteal, or subgaleal drainage. So people are using, the surgeons are using as per need the drainage accordingly. For example, as I mentioned you here, now there is a report of the better result when the drain is left above the skull as compared to when it is kept under the dura. And both the subdural and the subperiosteal method are found to be highly effective, but the mortality and the serious complications are less in the subperiosteal drainage. So the subperiosteal closed drainage system is technically easy, safe, and the cost-effective treatment strategy for chronic subdural hematoma. The absence of the drain is in direct contact with the hematoma capsule may reduce the risk of the post-operative seizures and limit the secondary spread of infection to intracranial compartment. Although the mortality and the complication of the subperiosteal drain were lower than the subdural drain, and the recurrence rate are more in the subperiosteal drain as compared to the subdural drain in few reports. So subgaleal suction drain is also an effective, simple and safe method, and it significantly reduces the incidence of recurrence, although the subgaleal drainage generally avoid the risk of an acute hemorrhage from the neomembrane injury which may occur during the introduction and removal of the subdural drain. There is a report of one acute subdural hematoma after the drain. It also reduced the chance of the brain parenchymal injury which could result from the blind placement of the subdural drain. And the duration of the drain, it also may differ, but people are doing, there is a controversy regarding the duration of the drainage for the chronic subdural hematoma. There is a report in favor of the 48 hours the closed drainage system is compared to the lower period drainage, not only in the bed rest and reduce, but the rate of the morbidity is also significantly. On the other hand, high recurrence rate was observed in less than 3 days and drainage group as compared to more than 3 days drainage group. So the prolonged drainage of did not increase the frequency of infection, and the 3-day drainage seems to be necessary, especially for elderly patients of over 60 years, and it is presumed that it take at least 3 days, and if drainage for the termination of the vicious cycle and the resolution of hematoma, but the restoration of a normal balance between the coagulation and fibrinolysis after the treatment. Irrigation is an important part, but it also controversy. Few people are not in the favor of the irrigation, few people are in the favor of the irrigation. So, but it is both are useful, and there are some benefits in that regard. Twist drill craniostomy is also an important role, such as the burr hole, and people are using, some telling twist drill, some telling burr hole. So the burr hole craniostomy is the most efficient choice of the surgical drainage and uncomplicated, and the burr hole craniostomy is associated with the lower recurrence rate, less complication, and treatment of chronic subdural hematoma through burr hole irrigation and close drainage under local anesthesia, simple and safe and effective. So the surgeon differ in their choice regarding the use of 1 or 2 burr hole. The 1 burr hole craniostomy with closed drainage should be sufficient to evacuate chronic subdural hematoma with lower or the similar recurrence rate as compared to 2 burr hole group. On the other hand, treatment with 1 burr hole has been found to be associated with the significantly higher post-operative recurrence rate, so the longer hospitalization length and higher wound infection rate as compared to the treatment with the 2 burr hole. So the 2 burr hole role is also better option and considered a high valued. Craniotomy is also an option, endoscopic treatment also an option, and you know that the endoscopic treatment is indicated for the removal of the solid clot under direct vision in organized and multiloculated chronic subdural hematoma. Endoscopic treatment could make the procedure safer with enhanced intraoperative visualization, and it may allow the identification and destruction of the neomembrane. Simultaneously, craniotomy is indicated in chronic subdural hematoma with significant membrane, multiloculated, organized, calcified, ossified, and there the ossified membrane cannot be excised, so we need the drill by high-speed air drill, and optimal surgical procedure for such a chronic subdural hematoma has not been established because it is hard to obtain brain re-expansion after the surgery, and the residual rigid inner and the outer membrane facilitate dead space and the hematoma recurrence multiple times, and this multiple tenting procedure could help in obliteration of the dead space in a large chronic subdural hematoma to prevent recurrence. It is not needed in every case, but we should know that it could be important. So the small craniotomy with irrigation and closed system drainage can be considered as one of the treatment options in chronic subdural hematoma, and the duration of the post-operative hospital stay, complications, and the recurrence rate have been found to be statistically lower in a small craniotomy group as compared to 1 or 2 burr hole craniostomy group. So the large craniotomy with extended membranectomy and technique could be required to reduce the recurrence rate in non-liquefied hematoma, multi-layer intrahematomal loculation, organized and calcified chronic subdural hematoma as compared to the small craniotomy with the partial membranectomy technique. So there are the multiple technique, as I mentioned you, because this disease present and in a different manner, so we have to deal in that way as the problem is encounter us. So as I mentioned a lot about this, and definitely there's a few things are left, but the prognosis, the mortality rate about 2% in chronic subdural hematoma. Although the chronic subdural hematoma is a benign disease, it is usually associated with the other underlying chronic disease. Long-term mortality continue up to 1 year after treatment in elderly patient due to these associated chronic disease, and the prognosis in the chronic subdural hematoma depend upon the age, GCS at the presentation, and associated illness like cardiac and the renal failure. So the prognosis is superior in better pre-operative and in younger age group patients, and duration of symptom should not have any effect of the mortality and the morbidity. As I mentioned, the new recurrence incidence of recurrence is between 5 to 33% after the surgery, and late recurrence are more common in the aged group as compared to the young group. And recurrence is significant more common in the thick hematomas, and early recurrence is defined as a return of symptom or reaccumulation of the hematoma after the surgery within 3 months. So the late recurrence may be defined as a reappearance or the enlargement of the liquefied hematoma or persistent chronic subdural hematoma roughly 3 months after the surgery. And the etiology of recurrence is not exactly unknown, but the many factors can present, and I mentioned a lot right now. And I want to definitely still the thirst of the knowledge regarding this topic is left, but I want to conclude this topic here, and I hope you could like it because I try to explain in detail. And I will continue this series in both languages, Urdu and English. I hope you liked it, and I hope definitely you will support me and share these lectures as much as possible. Thank you so much.